Okay, so this is Chapter 7, Glandular Tissue. We're going to start with some terms. The glandular tissue includes the lacrimal, salivary, thyroid, parathyroid, and thymus. So as you can see, the thyroid, parathyroid, and thymus are all going to be kind of in the same area in the neck area. And then you've got your salivary glands in your mouth and your lacrimal gland up in the outer or lateral corners of your eye. A gland is a structure that produces a chemical secretion necessary for normal body functioning. You have two different kinds. You have exocrine glands and endocrine glands. Exocrine glands is a gland that has a duct. An endocrine gland does not. So exocrine glands have a duct, endocrine do not. And if you think about it just logically, like your endocrine glands, think of like your glands that secrete hormones, your thyroid gland, none of them have a duct. They are, the secretion is poured directly into the vascular system, which is carried around where it's supposed to be used. So it just kind of spews the secretion into your vascular system. Your duct ones, they have to follow a little passageway, which is what the duct is, and be excreted in that area. So think of like when we looked at the parotid gland yesterday on that PowerPoint slide, it had the little duct that was carrying the saliva from the gland back here in your cheeks over to where it empties out closer to your teeth or your second molars. Same thing with your submandibular and your sublingual, you've got down under your chin. The submandibular one has to travel all the way up to the front because the opening or the duct is under your tongue. So it has the passageway has to go all the way up to that location under your tongue. So your lacrimal glands are paired almond-shaped exocrine glands, so they have a duct, and they are located, as we talked about early on the outer corners or lateral corners above your eye. So right below your supraorbital rim in the lateral corners is where your lacrimal gland is located. And then you've got your lacrimal tears or lacrimal fluid, is called lacrimal tears. So the duct is actually, there's a couple of places where it drains. One of the duct is in the corner of your eye, and if you notice when you tear, that's where the tears come out of. So each gland is located in the lacrimal fossa of the frontal bone up here, contains the nasolacrimal duct. So there's a duct that runs nasolacrimal, runs from the lacrimal to the nose. The lacrimal fluid passes over the eye surface, ends up in the nasolacrimal sac, a thin-walled structure behind each medial canthus, and ultimately draining into the inferior nasal meatus. That's why your nose runs when you cry, if you think about it that way, because it runs through that duct. Your lacrimal gland is innervated by the 7th cranial nerve. By now we should know the 7th cranial nerve is the facial nerve and the lacrimal nerve. The lymphatic drainage, we haven't done the lymph nodes yet, but we will in the next couple of chapters, chapter 10. Its blood supply is the lacrimal artery. So in contrast to normal moisture, the eyes, or even crying, there can be persistent dryness. So you've heard of or seen the commercials for dry eye. Keratoconjunctivitis. That's a kind of a syndrome. The tears keep your eye moist and they keep things from sticking to your eyeball, and they also, your eyeball, if it's dry, will burn a little bit. And so people with dry eye usually have itchy eyes. Salivary glands produce saliva, which is part of the defenses of the immune system. That part is important to know. Your salivary glands protect, as well as the beginning of breakdown of food products as part of the digestive system. So your saliva is very important. It does two things. It helps to protect your mouth, from bacteria and germs and invaders. And it also is the beginning process of breaking down your food. There are some things called salivary enzymes. You're probably familiar with that term, and they start the breakdown process of your food. Saliva lubricates and cleanses the oral cavity and divided by size into major and minor salivary glands. Both are exocrine glands and thus have ducts associated with them. So we talked a little bit already, parotid gland, submandibular, and your sublingual salivary glands, and they all have ducts associated with them, which makes them exocrine glands. Here's a picture of your major salivary glands and where they're located. When we studied the skull, on the mandible, we had the submandibular fossa, which was on the medial side of the mandible, and it was kind of like an indentation, and that's where your submandibular salivary gland sits. And then we had your submental fossas, where your sublingual salivary gland sits. And then you've got your parotid gland, of course, is the biggie right here in your cheeks. So the largest encapsulated major salivary gland is the parotid gland. Encapsulated means it's kind of enclosed. It has an outer circle that encloses it, and it occupies the parotid space on the posterior part of the mandibular ramus, anterior and inferior to the ear. So anterior in front of and inferior below the ear. So when you put your hands on the TMJ, the parotid gland would be right just below it. A lot of times when you are pressing on the parotid gland, when you're doing like your extraoral exam, it will cause saliva to be secreted. So the patient probably would notice that. The duct associated with the parotid salivary gland is the parotid duct or Stenson duct. You will need to know the ducts by their names that are associated with each gland. It pierces the buccinator muscle and then opens up into the oral cavity on the inner surface of the buccal mucosa of the cheek, right outside the maxillary second molar. That's where your parotid papilla is. The parotid papilla is where the opening of the gland is. So I don't know, those of you who are experienced dental assistants, you've probably done sealants before, or at least assisted when sealants were being done. And you put those little triangular cotton thingies over in the cheek area, and you cover the parotid gland to help keep the area dry. Innervation. So we're going to talk about innervation in Chapter 8 as far as efferent and afferent. There are two different kinds. The innervation is the efferent nerves of the otic ganglion of the 9th cranial or glossopharyngeal nerve. And it has afferent innervation. So this part of it, you'll understand better when we go to Chapter 8. Drainage is deep into the deep parotid lymph nodes, and the blood supply is the external carotid or retromandibular vein. So this is a picture of your parotid gland as it's located in your face. The parotid gland can be involved in cancer. So when people have cancer, even if they don't, you can get cancer in your parotid gland, but more commonly people get cancer in other parts of their head or neck, particularly smokers. So you will hear a lot of times how smoking increases your chances of oral cancer. So when patients have oral cancers, a lot of times they will use radiation treatment, and as they're using it, they are going through the parotid gland, or the radiation is hitting the parotid gland as it's making its way, the beam is making its way through to the lesion that they're trying to radiate. They can't help that. They damage the parotid gland or completely destroy the parotid gland in the process, at which point it will no longer produce and secrete saliva. So often what happens is the patient has a severely dry mouth when the salivary glands are destroyed. And that dry mouth allows for bacteria and invaders to come into the area, causing tooth decay and periodontal disease. So in a perio office, you'll see patients oftentimes that have had cancer and they've had radiation to their head or neck and their salivary glands have been destroyed and they've developed periodontal disease as a result. Oftentimes they can also damage the facial nerve and cause some paralysis or some numbness or permanent tingling in the facial area. The parotid salivary gland can also be pierced and the 7th cranial or facial nerve temporarily traumatized when an IA block is incorrectly administered using causing transient facial paralysis. Knock on wood, I have never seen this happen, but I know that it can happen. I've heard of oral surgeons having issues with this happening. So the patient, as a result, will end up with some tingling or some numbness in their face. Sometimes it's permanent, sometimes it's not. The parotid salivary gland is effectively palpated bilaterally during your extraoral exam. So you're going like this with your fingers and you're feeling the parotid gland. Start anterior to each ear, moving to the zygomatic arch and then inferior to the angle of the mandible. So you're kind of starting here and you feel the arch and then you're going to drop down here to the angle of the mandible. So you're going to come back to the angle. So you're just feeling right in here. The submandibular salivary gland is the second largest encapsulated major salivary gland. So you've got, has a capsule or is an outer shell around it. It occupies the submandibular fossa in the submandibular space. The duct associated with this gland is the submandibular duct or Wharton's duct. So one way that students try to remember that is the submandibular has an M. So if you make the M with your fingers and flip it over, it's the Wharton duct. This long duct travels along the anterior floor of the mouth and opens into the oral cavity at the sublingual caruncle, which is under your tongue. It is the most common salivary gland to be involved in forming salivary stones, as well as its mucus salivary product. Salivary stones, those of you who work in dentistry are probably familiar with salivary stones. Those of you who are not, salivary stones are literally like a stone. They're mineralized saliva, and they will form almost like a blood clot in an artery. They will form and they will get bigger and bigger, and eventually what can happen is they block the opening of the duct. So your gland is still producing saliva like crazy, and it isn't going anywhere because it's blocked by that stone. And they can become very painful because the saliva will back up, the duct will expand, the face can get swollen, and they can become very uncomfortable. A couple of cohorts ago, one of the students had a salivary duct in her parotid gland, and it was very painful, she said, and we couldn't get it out. So we took cotton pliers and we kind of grabbed a hold of the papilla, the parotid papilla, and tried to squeeze the stone through it, and it wouldn't come out. And so then we tried just maybe trying to break the stone by squeezing the cotton pliers and on it, and you could feel it, like you could literally catch it with the cotton pliers, but we couldn't get it to break. So eventually it passed on its own, thankfully, because it was like during midterm week or something, and she was like, I don't have time now to try and get to the dentist and get it taken care of. But it did end up passing. The duct lies close to the large lingual nerve, a branch of the 5th cranial or trigeminal nerve, which can be injured in surgery performed to remove salivary stones. It's innervated by the its efferent innervation is the fibers of the chorda tympani and the submandibular ganglion of the 7th cranial or facial nerve. We'll learn what that is in Chapter 8. And its drainage is the submandibular lymph nodes. And we'll learn about that in Chapter 10. The blood supply branches of the facial and lingual arteries are what supplies it, and the venous return of the gland is by the facial vein. And this is a picture of her palpating the submandibular gland. You do this in your extraoral exam. The sublingual salivary gland is the smallest, most diffuse, and only unencapsulated major salivary gland. So you have three major salivary glands. You have the parotid, the submandibular, and the sublingual. The parotid and the submandibular are both encapsulated. The sublingual is unencapsulated, so it does not have that outer shell around it. It occupies the sublingual fossa in the sublingual space at the floor of the mouth, so it's closer to the front than the submandibular. Think of your tongue as being lingual. It's going to be basically under your tongue, right in here. The ducts associated with the gland sometimes combine to form the sublingual duct or Bartholin duct, and it opens directly into the oral cavity through the sublingual caruncle. And there's a picture of the sublingual caruncle. And it's, if you lift up your tongue for orientation, if you lift up your tongue, those two little openings under your tongue are the sublingual caruncle, and those are the papilla. The sublingual salivary gland, its innervation are the fibers of the chorda tympani and submandibular ganglion, so it's the same as the submandibular. Its drainage is into the submandibular lymph nodes, and its blood supply is the sublingual and submental arteries, with venous return paralleling the arterial supply. So in other words, its venous return is back through the same way, the sublingual and submental. When you examine on your intraoral exam, you're going to place your fingers underneath the chin. You're going to feel the floor of the mouth for any swelling. Palpate around. It's going to be right around the canine area, from canine to canine. So you'll palpate and feel. If they had a salivary stone, you would be able to feel it under there. Then you have a whole bunch of minor salivary glands. They're smaller, they don't have names, we don't have to memorize them, but we just need to know we have them. There's a whole bunch of them, and they are not individually encapsulated, but surrounded by connective tissue within the submucosa. Scattered throughout the oral cavity in the buccal, labial, and lingual mucosa, the soft palate. So basically the whole rest of your mouth has minor salivary glands in it. So the bulk of your saliva comes from your majors, but you have minor salivary glands all over. That's why if you roll your lip out, the inner part of your lip is going to be wet. Your cheeks are always wet. The vestibules are always wet. In addition, your minor salivary glands, they're called von Ebner glands, are associated with the base of the large circumvallate lingual papilla on the posterior part of the tongue's dorsal surface. So you also have them along the dorsal surface of your tongue. And if you remember, you've got the V on there, and they're going to be along that V. Those are called von Ebner glands. And then note that minor salivary glands are not found in the gingival tissue. So the tissue that surrounds your teeth, your gum tissue, does not have salivary glands. The rest of your soft mucosa does, but not that gingiva on your teeth. Minor salivary glands, they have a single duct that secretes saliva directly into the oral cavity, since they are exocrine glands, just like your major salivary glands. They are unnamed. They have various nerves, various lymph nodes, and various blood supply depending on their location. We do not, since they don't have names, we don't have to memorize anything about them. This is a picture of something called a mucocele. A mucocele you'll learn about when you have oral path. It's when a salivary gland becomes enlarged and tender. It's the formation of a salivary stone within the gland, and it's called a mucocele. And you will see these on people. Like oftentimes they're just like in that picture on the inside of the lower lip, and there's a little like bubble, and it'll be filled with fluid. And most of the time you can just kind of press on it and it will pop. And then here's a picture of salivary stone. Xerostomia. I know in 101 you've heard of xerostomia, right? So xerostomia is a dry mouth. And there are lots of different things that can cause dry mouth. Medications can cause dry mouth. They're probably the #1 reason people have a dry mouth. They cause your saliva, your salivary glands to slow down on how much saliva they secrete. Your salivary glands also slow down at night when you're sleeping. And so you don't produce as much saliva. And if you remember, saliva has a protective mechanism in it to help keep bacteria and stuff from sticking to your teeth and the mucosa. And so when you go to sleep at night and your salivary glands kind of take a rest too, your amount of saliva you secrete is less. And so therefore it allows more plaque and bacteria to build up on your teeth and your gums. Important reason why we should brush our teeth before we go to bed, and why our patients need to brush their teeth before they go to bed, because they don't have that extra protection at night that they have during the day with their saliva. It's also the reason that people have bad breath in the morning, because the bacteria has been allowed to stick to the teeth and the gums and form a little film. So when you wake up in the morning and you run your tongue over your teeth and it's like slippery and tastes bad, that's all just bacteria that has settled on your teeth during the night. That's a pleasant thought, isn't it? So extensive cervical caries can result when you have a lack of saliva. So when your salivary glands can't keep your mouth moist, patients, particularly periodontal patients or patients with recession, where they have exposed cementum instead of just enamel, tend to have decay along the gum line because of the lack of saliva. Sjogren's disease syndrome is a syndrome where patients can have a decreased salivary flow. They actually have a decreased fluid flow. So any of their glands that produce fluid produce a lot less. Patients that have Sjogren's syndrome, which is not that uncommon anymore, oftentimes will have a lot of decay. They'll have a very, very dry mouth. And you'll know people who have a dry mouth versus people who don't, because when you wake up in the morning and your mouth is kind of dry, that doesn't even begin to compare to patients that have had like this syndrome. They can hardly swallow food because your saliva, of course, starts the digestive process and helps to bring the food down your throat comfortably. Like they can't eat breads and crackers and things like that because they have literally no saliva to help keep it from sticking all over the inside of their mouth. Does anybody have any questions as we're going? Okay. This is another picture of a patient with Sjogren's. They also can get some inflammation of the parotid gland, and you can see in his case it's very noticeable. Hyperkeratinization is another thing that can happen. This is particularly with patients that have that are smokers. It's called nicotinic stomatitis. So they get these white areas or patchy areas in their mouth. Your thyroid gland. So now we're going to go to the endocrine glands. Those were your exocrine glands. Now the endocrine glands. Your thyroid's your largest endocrine gland. It does not have any ducts. So endocrine glands secrete directly into the bloodstream. There's where your thyroid gland is located within your neck. And you can see the very top, there's the hyoid bone. There's another picture of it. The picture on the left is if I was looking at you. The picture on the right is like if we're looking from behind. And you can see how the gland kind of wraps around. And there it is where it's located in your neck and how it's located. Its innervation is sympathetic nerves through the cervical ganglia. Its drainage is the superior deep cervical lymph nodes. Again, both of those things we'll talk about more later. And your blood supply is your superior and inferior thyroid arteries. This is called a goiter. You may have heard this term before. It's an enlarged thyroid gland. This one's a very enlarged thyroid gland. Here's just some information about thyroid problems. Women are at a higher risk. They're 3 times more likely to develop thyroid cancer and over the age of 50. Thyroid disorders, you can have hypothyroidism or hyperthyroidism. So in other words, your thyroid can not secrete enough, and that would be hypo, or it can secrete too much and it'd be hyper. People who have hypothyroid or not enough usually tend to gain weight. They have fatigue, depression, things like that. People who are hyperthyroid, they're almost like your nervous type people. They have heart palpitations. They have too much. There's a picture of them examining the thyroid area. You've learned how to do this on your extraoral exams already. And then you have your parathyroid glands. Again, they also are endocrine glands. There's 4 small endocrine glands, 2 on each side. And this is just another picture of how they're located. They're not palpated during your exam. Here's their innervation and drainage. Their blood supply is the inferior thyroid arteries. And their venous return is the superior, middle, and inferior thyroid veins. So you can see how they're pretty much just named after what they are. And then you've got your thymus. Your thymus is another endocrine gland that's ductless. It's part of your immune system. Oops, that's not what I wanted to do. And its blood supplies the inferior thyroid and internal thoracic arteries. That's it on the glands. Anybody have questions on the glands? What do you need to know for the glands? That's probably what your question is. You need to know your 3 major salivary glands. You need to know your terminology. So encapsulated, unencapsulated, major and minor. You need to know the openings or what the duct openings are called. The Wharton is the opens the submandibular. The Bartholin, the sublingual. So those 3 things you'll have to memorize. For now, I would say you're just going to need to know the blood supply. We have not talked about the lymphatic drainage or anything like that yet. We will in future chapters, so do not worry about memorizing all of that. Those few key things that I just mentioned are really about all you're going to need to know. Your thyroid gland, your parathyroid, your thymus, those are all your endocrine glands. They secrete a thyroid hormone. In your body, you will see patients, lots of patients in clinic, particularly middle-aged women who take thyroid supplements because their thyroid has stopped secreting as much as it should. And they've noticed it because they feel lethargic, they've gained weight. Most of you have probably already heard that or are familiar with the idea that if you don't have enough thyroid, you're going to gain weight. Anybody have any questions?
Can you repeat what you said was most important? I'm sorry.
I'm sorry, you faded out. Can I repeat what?
Can you repeat what you said was most important?
Okay, so know your terminology. What does encapsulated, unencapsulated mean? What is ductless? That kind of thing. The terminology is at the beginning of the chapter. There's like 10 terms. Know your major salivary glands. Parotid, submandibular, sublingual, and the duct associated with each of those glands and where the duct opens up, which you should already know from doing the surface anatomy. As far as your thyroid gland, you know that you have your thyroid, your parathyroid, and your thymus, which are all endocrine glands, meaning they secrete directly into the bloodstream. And just know the blood supply to those for now. Don't worry about the lymphatic drainage and the nerve innervation. When we get into the nerves that we're going to discuss now, we'll talk about the nerves. And then when we get to chapter 10, we'll talk about the lymph nodes and the drainage. So very few things to know. Basically, there's a chart on page 159, and it tells you pretty much everything in a summary. Anybody have any other questions? So let's take just like a 5-minute break, and then we'll start chapter 8. Sound good? We're not going to, there's chapter 8, I believe, has 2 weeks scheduled out for it, 2 lectures.
Which PowerPoint are you going to use for the chapter 8? Because there's like 4 different ones in there.